This lecture we're going to talk about is critical care ultrasound DVT evaluation. Most of the information is presented is from these three books. There is other resources such as recent journal articles and stuff like that, but I think most of the information can be found in any of these. These are all very good books to read through. So let's talk a little bit about clogging of the pipes, venous thromboembolism. When are we going to be using this? We're probably going to be using this when we have an unstable patient that we are not sure if they are having a pulmonary embolism as the cause of their decompensation. Most of the time, if you're in the unit or in the emergency room and thinking about a DVT, even if you may do one yourself, you probably will order a full Doppler ultrasound from the radiology department. And even if you do find negative or positive, if this is your concern, you probably really should order a full DVT ultrasound complete study. Remember, we have focused questions. Is the common femoral or popliteal vein fully compressible? And the reason we ask this is if we do find a non-compressible vein and a patient is hypoxic and unstable, we may actually just go ahead and take the decision to start a heparin infusion or start the treatment for DVT in that scenario. The probe type you're going to use is a vascular probe, a linear array or high frequency. This will allow you to be able to have a high resolution. So most are unable to sit in the best position to evaluate with the legs hanging off the bed. Most of our patients are supine and are unable to really move. Visualization might be improved by externally rotating the leg. The amount of pressure that you should apply should be even and just enough to show some small deformity in the artery visualized. And this is a very important concept because you can miss early thrombosis if you compress too hard. Remember, apply perpendicular to the skin. A lot of times, especially with beginners, I see that they, especially with obese patients, sometimes your probe can become less perpendicular, and that really will affect your evaluation. So a little bit more about venous thromboembolisms. The majority of pulmonary embolisms arise from the lower extremity. Simple compression ultrasound has good sensitivity. Incomplete compression of anterior and posterior portions of the vein and can cause issues. And complicated Doppler techniques adds little utility. Just a few years ago, there was a study by Bernardi and others that had about 2,100 patients. The 2-point study of the vessels in a D-dimer versus a whole leg color flow Doppler was equivalent. The initial prevalence of a proximal DVT was also similar in both groups, suggesting that most are common femoral or popliteal. So the areas that you're going to visualize is the proximal femoral vein, evaluated first just below the inguinal ligament, and scanning should continue down to the bifurcation into the deep and superficial femoral. And I'll show you the 4 points that we kind of looked through. The second area is the popliteal fossa. You can do upper extremity veins, but honestly, they're a lot more difficult, and most of the time, they may not cause the pulmonary embolisms. You can also miss calf veins, but they're also not as normal for them to become worrisome pulmonary embolisms. Here's just an anatomy slide showing the common femoral, the deep femoral, the greater saphenous takeoff, and then the popliteal. Obviously, we're not measuring the anterior tibial or posterior tibial peroneal veins. So there are a few concepts. One of them is a 2-point DVT exam, which is the common femoral and the popliteal vein, which is well validated in outpatient populations. The one we're going to recommend is 3-point, which adds in the superficial femoral vein. This is recommended since studies show higher incidence of clots isolated to superficial femoral veins in asymptomatic patients. And Corey and others also found sensitivity went from 88% to 82% and recommend a 3-point exam. So you can see here, this is the performance of a femoral DVT exam. You can see slow and steady pressure. This is the kind of pressure that you should be placing. And if you are able to get the patient to sit with his legs hanging over the bed, you could do popliteal similar to this. But a lot of times what I do is I have to just prop the leg up and put my hand at the back end of the knee. So here's a femoral vein on the bottom left, good compressibility, good slow pressure where you can compress the whole vein, and just enough pressure to compress the artery a little bit. Here on the top right, you see the same maneuver being performed. You can see us pointing to the femoral artery. And then there's a patient with a clot with an uncompressible vein. So here's just a picture of what I mean. The first point you're going to see is the greater saphenous takeoff. And where you see this is right below the inguinal ligament. You see the femoral artery, the common femoral vein, and the greater saphenous takeoff. The right is the picture with it compressed. Here's a clip of us doing that. So here you see the artery on the left and the greater saphenous vein takeoff on the right. You can see it's totally collapsing. I do make a little bit more quick movements rather than what I just showed you with the previous slide, but you can make a little bit slower movements is okay. Here's the deep femoral takeoff, so superficial femoral and deep femoral. So once they split, you can do another compression screening then. Technically, you can do as much screening as you want. You can do all throughout, and you can actually go even a little bit lower if you wanted to. So this is a common femoral becoming the superficial and deep femoral. Here you see the popliteal area. Usually, most times the vein is on the superior aspect, so you can see the artery and the vein. You see the collapsing. And there you see the vein collapsing. It's similar to when you guys were evaluating the internal jugular vein. Sometimes you can confuse the lymph node. So remember, just like what I explained in the vascular module when you're like looking for the vascular couple, you do want to see the artery and vein in combo. Here you can see the lymph node up top. I have seen people confuse that for a clotted femoral vein. But remember, most of our patients have a couple of femoral artery and vein. The only time you may not have this is if you have a high population of vascular surgery patients. Here's just another picture of a vein thrombus and long axis. One of the things I want to relay from this slide is that if you do see a short axis and you're not sure, remember you can always place it in a long axis to see if there's a clot. So you may ask, I've never been trained on this. Remember, you are becoming an expert at evaluating vessels, and as you do more and more collapsibility tests on your internal jugular, you will see clots there also. And that will, even though they are not DVTs, they will help you identify what a clot feels like as well as good compressibility. Critical care providers and emergency physicians can perform limited ultrasound for lower extremity with good sensitivity in patients with high pretest probability. You can see all these articles. There's a systemic review of emergency medicine performed and diagnosis of exclusion of DVT, which showed really good sensitivities and specificities. I don't mention it here, but there was an article done where medical students were trained, similar to a lecture, 30-minute lecture, similar to this. Then they had 5 models where some had positive, some had negative. And then what they did was, in the emergency department, anybody who was getting an ultrasound scan over the next 6 months or however long the study was, the medical student would go and do their limited DVT scan. Obviously, they missed a few, but if they were positive, then it was almost 99.8% that also the ultrasound, official ultrasound, was able to see a DVT. So what I wanted to relay from kind of a final teaching point from that is that if you do see a clot and you have been doing a lot of this and you have the correct situation where you're unable to send the patient out of your unit or out of your emergency room, you can possibly think that maybe there's a pulmonary embolism involved. That may be why the patient is hypotensive or hypoxic. Here's another image with just where there is a clot there. So whoever's doing this is putting slight compression, and you can see that the vein is not collapsing fully. So this will be a partial thrombus possibly, and this may have been in the carotid region, not the femoral, but it was just to illustrate the point where how a clot looks. This I just wanted to show you since you can see the guide wire going into the vein, but also on the left, you see like a white speck. That's actually could be air. I have seen that with neck internal jugulars from patients that have ENT surgery done. But also in the vein, you see a little thrombus on the bottom portion of the vein. Now, we can't tell for sure because we don't see the collapsing vessel here, but when this patient was being collapsed, it probably might have been collapsed partially. Here's another patient with either a thrombus or a calcification. They are collapsing it, but they're not collapsing fully. Whoever's doing this should probably collapse just a little bit more, put a little bit more pressure on to see if that is a calcification or if the vein actually kind of collapses fully. So remember, we don't use venous thromboembolism to do a full final DVT scan with color Doppler and manipulation of calf to see if we can get more flow. The full, when you order a DVT ultrasound through the radiology department, they do that. But for us, we're asking a focused question: is the common femoral fully collapsible? If it's not fully collapsible, then you may want to consider that there is a DVT. Now, this is for a DVT, but remember, this is the same technique you use for your internal jugular vein or subclavian vein prior to access. All right, thanks a lot.